Chapter 50, The Child with Musculoskeletal Alteration continued. Developmental dysplasia of the hip, DDH, describes a variety of disorders that present in different forms at different ages. Dysplasia varies in severity from quite mild to severe dislocation. DDH can be present at birth, which is called congenital, but in some children it develops after birth. The exact cause is unknown, but genetic factors may play a role. Risk factors include being the firstborn child, being female, breech position, and low levels of amniotic fluid in utero. The symptoms of DDH vary according to the age. In neonates, it's characterized by instability of the hip. The femoral head can be displaced partially, which is called subluxated, or fully dislocated from the acetabulum by the examiner. The hip sometimes results in a dislocated position and can be reduced on examination. This condition can be detected by performing the Orlanti and Barlow test. Infants beyond the newborn period exhibit asymmetry of the gluteal skin folds when lying with the legs extended against the examining table or when the infant is being held upright with the legs dangling. The affected hip has a limited range of motion, and asymmetric abduction is present when the child is placed supine with the knees and hips flexed. The femur on the affected side appears to be shorter than the one on the other side. Any abnormalities in an older child's gait should be carefully evaluated as possible signs of the condition. Walking children may exhibit limping, toe walking, or waddling gait. Bilateral dysplasia is always more difficult to identify than unilateral dysplasia because there's not a normal hip to use for comparison. A well-trained nurse or physician screens for DDH at birth and during each routine infant well check visit by carefully performing the Barlow and Orlanti maneuvers. An ultrasound of the hip is used to confirm DDH in infants. Plain radiography of the pelvis usually reveals a frankly dislocated hip in individuals of any age. Early diagnosis and treatment are important for maximizing the likelihood of a successful outcome. Treatment depends on the age of the child at the time of diagnosis and on the severity of the dysplasia. The primary goal of treatment in the DDH, regardless of age, is to facilitate normal development of the hip socket. In newborns and infants younger than 6 months, a Pavlik harness is a treatment of choice for a hip that's dislocated and can be reduced by the examiner. The Pavlik harness maintains the hip in flexion, abduction, and external rotation. This device consists of chest and shoulder straps and foot stirrups. There's a picture of this in figure 50.9. Initially, the harness is worn continuously. This bracing method can be the only treatment necessary to allow the hip to mold and grow normally, promoting developmental of a functional hip socket and well-formed femoral head. Hips that remain unstable become progressively deformed as the skeleton matures, resulting in functional disability. Parents must be taught the proper use of the harness because improper positioning of the infant's hip can cause interruption of the blood supply to the head of the femur, which will result in avascular necrosis, which is tissue damage caused by an inadequate blood supply, or a femoral palsy. Teach parents to observe for equal leg extension in and out of the harness. In addition, skin care, techniques for holding, feeding, and diapering, and the importance of vigilant follow-ups must be emphasized. In older children, other treatment options include surgery, Bryant's traction, and a spica cast. Teaching for the Pavlik harness includes wearing a long t-shirt under the harness to protect the skin. Diaper goes under the harness as well, and teaching parents to watch for signs of skin breakdown. Leg calvae paraths is a disruption of blood flow to the head of the femur. Due to the lack of blood flow, the bone dies, which is called osteonecrosis or avascular necrosis, and stops growing. The most common symptom of this disease is persistent pain of the hip that worsens with movement. Pain may be intermittent over a period of weeks or months and can be felt in other parts of the leg, such as a groin, thigh, or knee. Patients may have a limp or limited range of motion. The most serious complication is permanent deformity. If the femoral head protrudes outside the acetabulum and the healing process within the femoral head is incomplete, the femoral head will now flatten over time and take on a misshapen appearance. Initial treatment includes anti-inflammatory meds, range of motion exercises, and bed rest. If improvement is not seen within 7 to 10 days and the child is still unable to abduct the hip, alternative methods of treatments are considered. Traction, Petri cast, or abduction braces may be recommended. Clubfoot represents a congenital dysplasia of all tissue, which means bone, muscle, ligaments, nerves, and blood vessels below the knee. Clubfoot can be diagnosed prenatally by ultrasound. Radiographic imaging is rarely used or necessary for assessment of a clubfoot. The deformity is easily recognized on clinical examination. The goal of treatment for a child with clubfoot is to reduce or eliminate all of the components of the deformity so the child has functional, structural, mobile, pain-free foot. Additionally, treatment goals include satisfactory appearance, ability to wear normal shoes, and the avoidance of unnecessary or prolonged treatment. The standards of care for clubfoot treatment is the Ponseti casting method. This method requires weekly gentle stretching and manipulation of the misaligned bones, followed by application of a well-molded long leg plaster cast. The cast maintains the correction obtained by the orthopedist and allows for further relaxation and softening of the tissues with atraumatic remodeling of the abnormal joint surfaces. Correction of the deformity is usually obtained within 6 to 8 weeks of casting, with percutaneous tendo-Achilles lengthening, called TAL, being frequently performed before the final cast application to correct the equinus contracture. The TAL is generally performed in the clinic setting using a topical anesthetic cream or needleless injectionable lidocaine. A final cast is applied and maintained for 3 weeks. On completion of casting, the foot will appear overcorrected. Correction is maintained through the use of abduction orthosis full-time for 3 months, followed by 12-hour nightly use until at least 2 years of age in an effort to prevent reoccurrence of the deformity. Information about the child's clubfoot and treatment protocol can be helpful in reducing the anxiety and guilt experienced by many parents, and it will facilitate treatment adherence, which leads to improved patient outcomes. Prepare the families for the expected disruption in their child's care, such as difficulties with dressing, sleep, and play, often seen with the initiation of casting and bracing. Knowledge that their child will adapt, usually within 24 to 48 hours, is helpful to families. Families must receive thorough and ongoing education about proper neurovascular, skin, and pain assessment to help prevent potential problems. Positioning, bathing, and skincare must be addressed with clear verbal and written instructions. Inform families whom to contact with questions or concerns. Family involvement and commitment to the treatment is critical for a successful outcome. Nurses can advocate for their young patients and help improve family adherence through frequent reinforcement of treatment and protocols and parental encouragement with ongoing education, phone calls to the home to address problems and concerns, frequent follow-up appointments, and facilitation of a parent support network. Muscular dystrophies include more than 30 genetic diseases. These are progressively degenerative inherited disease that affect the muscle cells of specific muscle groups, causing weakness and atrophy. We're going to focus on Duchenne's form of muscular dystrophy. It's the most common hereditary neuromuscular disease, and it's X-linked recessive. Onset is usually before 3 years old, manifests between 3 to 6, and rapidly progressive. They'll have a loss of walking usually by 9 to 12 years. Death is in the late teens from respiratory failure, heart failure, and pneumonia. The disease is progressive, so once it hits the respiratory system, the child has a hard time fighting off any respiratory illnesses. Manifestations include progressive generalized weakness and muscle wasting, affecting the limbs and trunk muscles first. Calves often are enlarged. They'll have a waddling gait. They'll have lordosis, cardiomyopathy. They'll use the Gower maneuver and a cognitive disability common. The Gower maneuver is when a child has to use their hands and arms to walk up their own body from a squatting position due to the lack of hip and thigh muscle strength. Children with a positive family history are especially at risk for muscular dystrophy and should be monitored for clinical symptoms. Serum creatine kinase, or CK, levels are elevated in the early stages of the disease, and then they decrease as the muscle bulk decreases. Electromyography and muscle biopsy may also assist with the diagnosis. The therapeutic management of the child with muscular dystrophy is aimed at maintaining ambulation and independence as long as possible as muscle weakness progresses. Contracture furthers reduced mobility and independence. Surgery, bracing, and physical therapy contribute to keeping the child as mobile as possible. Later, therapy is directed towards maximizing sitting capabilities, respiratory function, and self-care. The prevention of obesity to facilitate mobility and care is a priority. Prompt attention to infection, especially of the respiratory tract, is essential. Nursing intervention for the child with muscular dystrophy include coordinating a variety of healthcare services. Anticipating the child's further need requires a sensitive yet knowledgeable approach. The family's ability to cope with chronic illness and the poor prognosis of a muscular dystrophy should be assessed. Over time, the child's mobility and self-care abilities should be monitored to ensure independence for as long as possible. Maintenance of activity and self-care function is important to the child and the family, and independence must be fostered within the limits of safety. Activities such as swimming that promote range of motion and mobility for as long as possible are helpful. As the disease progresses and movement is increasingly restricted, the nurse can suggest activities that take less energy but keep that child involved with peers. The potential for weight gain and respiratory tract infections and the adequacy of support system must be regularly assessed. The needs of a child trying to fit in with his peers. Specific suggestions about dietary modifications to control weight may be necessary. The nurse can educate families about how to make dietary changes without making food source a controversy. To reduce the chance of life-threatening respiratory infection, the child should be protected from children with respiratory and contagious diseases. Parents should be taught how to perform basic nursing tasks and should be referred to agencies that can assist with home care and equipment, such as motorized wheelchairs. Extended family and support groups such as Muscular Dystrophy Association of America can provide needed emotional support and specific assistance as parental energies are exhausted. In addition, the needs of the grieving family should be addressed.